Hey, there we are. Hey, everybody. It's Kevin and it's Donna, and welcome to another episode of the Med List. Donna, so I got some bad news for you. My
Oh,
Cougs, they lost. It is March Madness time, and we lost. And then right after we lose our head coach. He transfers and goes to another school. And so it was a
no.
brutal back-to-back whammy. But I am still committed to using an analogy that I thought of, just before getting on with Shawn of how can
Mhm.
I use March Madness and basketball in this study. And so I'm going to plug that in. I promise. There's a teaser.
Oh, can't wait.
Teasers from you, Donna?
Just, deprescribing for everybody. I know I talk a lot about geriatrics, but today we're going to be learning about how younger adults and middle-aged adults too can deprescribe.
I love it. Let's do it. It's funny. So off camera, you guys couldn't see it when we were doing the intro, but both Don and I adjusted in our seats, like almost like a buckle in episode, because I think that Shawn is going to be a rock star on this, and you guys will all really love it. So one thing that I saw today, I saw a meme, Donna. It was something like, "You were about to push me beyond where my medications can keep me," something along those lines, like basically as in a joke, like, "Hey, you're pushing me too far," kind of deal. But the
Yeah.
interesting piece about that is that medication utilization in the senior population, as you were mentioning, is somewhat known that mom and dad, grandma and grandpa are taking a lot of pills, and that's a problem. But the
Yeah.
one thing that I fear that we're not recognizing early enough is the same thing that all of us struggle with, and that's looking in the mirror and getting a good idea of what's happening in my health, what things am I doing. And I'm so excited to have Shawn join us to talk about something so important because if somebody hasn't heard this, we are having a mental health crisis in this nation. And so, what a great guest to bring on today.
Yeah. So, and welcome, Shawn. Thank you so much for being with us. We have Dr. Shawn Gill with us today. And I just want to do a little introduction and share with everybody about you, Shawn. So, Dr. Shawn Gill, he's a PharmD and is the founder of Deprescribe Solutions, a clinical practice dedicated to reversing early stage chronic diseases in mental health, early stage hypertension, and type 2 diabetes. His mission is to help individuals reduce their medication burden and deprescribe off their medicines by empowering patients to implement evidence based lifestyle interventions to successfully optimize their health and well being. And Shawn also has a great blog called Buds, and Bud stands for Build, Understand, Discipline, Stillness, really incorporates that whole lifestyle change and journey that we all strive for.
I love it.
So I just, welcome so much, Shawn, and thank you so much for being with us. I can't wait to explore more about what you're doing for our younger and middle-aged adults.
Donna, Kevin, thanks for having me.
Yeah, absolutely, buddy. I think that, to start things off, I really wanted to get your perspective, Shawn, on a couple things. We're just talking offline right before the show started, and really mentioning these aspects when it comes to television advertisements, when it comes to venture capital initiations. Mental health is a big focus. There's a significant mental health issue going on in this country, and oftentimes that's due to a lack of a number of providers to offer things like cognitive behavioral therapy or general counseling, that we can be able to leverage things that actually have better overall outcomes than utilizing medications in general. There's just a shortage of individuals to deliver that individual care. And two, we're a quick fix society, Shawn. What are your thoughts there, bud, when it comes to the kind of the perfect storm happening right now with our young adults and youth in increasing the rampant level of over medication, especially in mental health?
It's a good question, Kevin. I think I see it quite often in my practice as well. Being in this sort of age of instant gratification, it's quite easy for patients to go to a physician or go to their primary care provider. And it's very transactional in nature as well. I mean, of course, if you're at a point in your life where you're suffering from anxiety or depression, it's almost like a low point in your life. And you maybe consult your parents or your friends, and if unable to make any changes in your lifestyle, the last resort is almost like going to a physician, getting sort of seeking help in that sense. So that transaction, it's almost like you kind of spill out what you're feeling, what you're dealing with, the stresses in your everyday life. It can be common for the only way the physician may feel they can help you in that sense is to write a prescription. And that's what we are commonly seeing in, I guess, all of our practices, specifically working in family medicine. I see quite often all ages have been impacted by this mental health epidemic since the pandemic. And what I try and do with the prescribed solutions is when patients first come on those medications is coming back to the roots of what we learn in pharmacy with medication therapy management and pharmacotherapy, such as establishing goals of medication therapy at the outset and kind of telling patients to understand that, with mental health specifically, it is a process. And of course, medications can be a valuable tool, but it's just one aspect of our mental health toolkit. And what I try and do is help patients sort of increase and also lean on and develop other sort of aspects of that toolkit, whether it's mindful based stress reduction, whether it's mindfulness and stoicism or philosophy, whether it's exercise, journaling. These are all things that I've utilized in my own battles with mental health. And it's just a matter of sharing my perspective as a clinician, but also as someone who has sort of their own struggles in mental health.
Yeah.
So Shawn, could you just tell us, and just to back up ever so slightly, just a little bit more about you and how did you connect with this particular patient care group that you're working with? How did you develop into this niche?
Well, deprescribing has always been on my radar, Kevin and Donna. Even the concept, I came across it in 2013 during a geriatrics elective when I was still in school. And I remember at that time, I just kind of bookmarked it in my mind and thought, in geriatrics, of course, you have grandpa and grandma and 25 medications. There's polypharmacy, there's prescribing cascades, adverse effects, interactions. It's almost like low-hanging fruit in that population, but it's still very difficult to deprescribe. But I always thought that this concept should be applied right at the onset when an individual is being prescribed an antihypertensive, or they're being prescribed metformin for their early stage diabetes or pre-diabetes, or an individual seeking out therapy for anxiety, they get prescribed an SSRI. That's the best time to sort of outline, okay, what's the duration of therapy here? What are the goals of medication therapy? What parameters are we actually looking to target? What changes do we want to see in those parameters, and establishing a time frame? And I always thought that deprescribing should be utilized in that concept, more from a preventative, proactive measure, as opposed to something that we do statically when someone takes a bunch of medications and there's interactions or later stages of life in geriatrics. So from that lens, because I work in pediatrics and I work in family medicine, I have a lot of opportunities to see patients from all ages and all demographics, and they're all in different stages of their journeys with their medication. Whether it's a refill for an SSRI, and I look at the patient profile and I see they've been on this medication for 12 years. Okay, so then backing up, talking to the patient, instead of just handing them the prescription, off you go, we start that dialogue and we have that conversation and we go back and say, okay, what was it 12 years ago that led you to coming onto this medication? Maybe it was a car accident, maybe it's a tragic moment in their life, stress at work, whatever it may be. We know time heals all wounds. And having that sort of dialogue, having that conversation with the patient, it really leads and opens up a lot of opportunities. Patients may kind of dive into past experiences trying to come off these medications or switching to medications, and sort of getting that thorough history helps me kind of outline next steps in their journey. Also, the best time, in my opinion, to kind of start that conversation with deprescribing is right when you get a new prescription. Oftentimes, I've seen cases all across the board and so many different stories that would blow you away, from especially nowadays, coming back to your earlier point, Kevin, about kind of the society we live in now, where kind of it's instant gratification. We're so used to having our problems fixed right away. Sort of the expectation is to get a prescription, and it's so easy to kind of access these medications. I see individuals come in to see a walk-in physician and they're stressed at work, or they got a deadline coming up, or little minor things. And it's so easy, like I said, to reach for that prescription pad and say, okay, here's your Zoloft, 25 milligram, 3 months, 2 refills. And then it's almost like you have to ask yourself, back to pharmacotherapy 101, is this medication appropriately indicated? Or kind of look at it from a risk-benefit analysis of, okay, these medications may help in the short term, but are we putting the patient on a potential sort of roller coaster where 3 months can easily turn into 3 years? And I've seen that often in my practice as well, where people start these medications and there's no real guidance on how to get off of them.
Yeah. Wow. That's so helpful. So for the audience, Shawn went into some incredible detail on something that I'll call pre-prescribing right now, really looking at prior to having a medication given to you from a physician, what things can be done from a workup standpoint in what is often called in medicine a shared decision-making process. In other words, you have an idea of, here are the timelines that I'm looking to achieve these goals and these treatments. Here are the things that I will tolerate as an individual from a cultural, from a personal standpoint, and then allow the individual, being you guys, the patients, and your family members, to be able to make those decisions along with the clinician so that there's a better buy-in. The other important point to be able to note is that that exact same thought process of the buy-in comes with the element of being able to taper off or move away from a medication that was initially prescribed. So in other words, instead of us thinking about this being a lifelong fix that is going to be continuously necessary throughout our lives, when we go in and talk to our physicians, Shawn is saying, you need to go in and think, how can I get this fixed at this period of time? What other modalities or what other thing can be done along and coalescence with it that will help? And then how can I get off these medications long-term? So thank you so much, Shawn. That was perfectly worded on your part. The one little tidbit, Donna and Shawn, is I saw a study when I was prepping for our episode today that showed that before the pandemic, there was a 129.6%, so over double the level of prescribing of antidepressants in teenage women, pre-pandemic to post-pandemic period of time. So a massive uptick and increase in that population base in general. And Shawn, I think the one thing that is interesting that I'd love to get your perspective on, if any of us know a family member that has been on an antidepressant, the one thing that is so common is for them to play a little bit of popcorn of, I'm on the antidepressant, I'm off of it. Now I'm back on the antidepressant, I'm off of it. And that movement back and forth reminds me of a quick story that I'm sure you guys can both relate to. I remember during one of my first rotations, I was sitting next to a doc and we had a young medical student come in and said, the patient, they said they're not going to do the taper any longer. And it was an antidepressant at that time because they were having electric-like shock waves go from the tip of their head to the bottom of their toes. And I'll tell you this, Donna and Shawn. So I grew up in a rural setting. So dogs will wear shock collars and cattle will have electric fences. When cattle hit an electric fence or a dog gets shocked, they don't do that same activity again. And so it's very interesting to be able to tie those things together with human behavior and think, a really good way for people to struggle mightily from getting off of a drug is let them experience a significant withdrawal.
Mm-hmm.
Mm-hmm.
Thoughts there, Shawn? I know we got a great study to cover, but when it comes to that prescribing process, your pre-prescribing you just talked about, can you talk about how we should do a better job of talking about withdrawal early on?
That's a great question, Kevin. I think it's important to have patients fully on board with kind of what they're getting into as well. And oftentimes I think that's missed, especially in my own experience. I mean, you guys have seen it. Obviously, we're in different countries. You guys are in the United States, we're in Canada, but I think both countries are really struggling in primary care with accessibility. And also just in general, like being in the GTA, the Greater Toronto area here, we have a huge population boom. And there's a lot of accessibility issues with patients getting in face-to-face with a physician. So when you're there in the office, you have maybe 10 minutes, 15 minutes to kind of relay all this information to the physician. They prescribe these medications and they do go over that. They go over kind of side effects to look out for potentially. They do a little bit of counseling on the medication. And one of the things I do as a pharmacist is when patients come to me with a prescription, I always ask them, so what was the discussion about the medication with the physician? Usually they mention a few side effects, but there's no mention of long-term issues, withdrawal, potential side effects down the line as well. So I think it's very important early on that patients, as a part of full consent to take these medications, understand the potential long-term implications of coming on these medications. And we know now, Kevin, especially a lot of great work is being done out of the UK with Mark Horowitz, Dr. David Taylor, Dr. Joanna Moncrief on these issues of sort of having that conversation and dialogue about what these medications do long-term and the realities of the fact that, we have a lot of great guidelines on anxiety, depression, on how to initiate these medications, how to taper, cross taper, and switch medications, but we don't have much guidance on how to actually effectively get patients off these medications. And the guidelines are all kind of outdated with a linear taper approach where, say you're on 100 milligrams of sertraline, the recommendation is, 1 week of 50 milligram, 1 week of 25, 1 week 25 every other day, and off you go. And in clinical practice, I've seen some success stories. There are patients that are able to kind of rough it out And they may experience these withdrawal symptoms, but they're able to kind of maintain and get off the medication successfully. But then you have another cohort of patients where they get these intense withdrawal symptoms that can manifest with physical symptoms, like you had mentioned, Kevin, with brain-like zaps or electric shocks, dizziness. A lot of my patients, they do struggle with nausea, upset stomach, abdominal discomfort, almost like a pit in their stomach feeling. And of course, there's the mental and psychological symptoms that can come back as well: anxiety, rumination, etc. So it's really about kind of counseling and coaching our patients so that they understand that deprescribing is not an easy process. And when you're on these medications, like I said, it's all about establishing timelines, our goals. Once we hit those targets, once we feel like we're in a place that our life is back on track, how can we successfully move on and come off these medications? And one of the analogies I like to use, I picked this up in one of the papers on withdrawal and deprescribing, and the SSRI specifically, was that they had described that withdrawal often occurs in wave-like patterns. So I always try and tell my patients, you have to kind of be like Laird Hamilton here. You have to adopt the mentality of a surfer, because there's going to be peaks and waves with withdrawal, and we can't really anticipate when they're going to come. But when they do come, that's when we lean on our mental health toolkit. That's when we lean on things like physical exercise, the relationships that we have with our spouse or our families or our friends, journaling techniques, anything to get you through that sort of intense withdrawal. And even from the physical side of things, I also provide sort of coordination with my patients, with their primary care physicians, to say, hey, in case there's intense nausea, maybe prescribe a medication for that. Or if there's intense dizziness or vertigo, we have options for that. So there's ways that we can kind of beef up our defenses in moments where withdrawal does occur, that we can anticipate and we can overcome and we can outlast the withdrawal. And it's a process. And that's the thing with deprescribing as well, especially in the realm of SSRIs and antidepressants for anxiety and depression. It is a long process. And that's something I'm learning as I continue with my patients and sort of building my program, is that we kind of have the expectations that depending on how long the patient's been on the medication, you're looking anywhere from 6 to 24 months potentially. But some patients are able to they're more motivated. They're able to kind of sometimes go cold turkey and just kind of power through. But then other patients are much more sensitive. They've been on these medications for longer periods of time. They have other underlying issues, maybe like a neuropathic pain or other sort of underlying medical conditions that can make the withdrawal even more intense. So it's really a case-by-case basis. But I think back to your question, Kevin, making sure patients are informed about the risks, making sure patients are informed that with these medications, specifically with mental health, withdrawal is a major hurdle and potential obstacle with coming off these medicines. So even when initiating it, having that conversation, I've had a few patients say, you know what, maybe I'm not comfortable taking this medication. Maybe I'll pursue alternatives, CBT therapy. I'll consider more exercise, or I'll consider just kind of dealing more directly with whatever situation I'm in. So having that conversation at the onset, I think, is very important.
Love that.
Shawn, when we're talking about the whole withdrawal too, I know that there is sometimes you need a little back and forth. So thinking about the clinicians, how are we trying to figure out or share with someone that, you know what, it's not the return necessarily of a depressive episode or of an anxious episode, but it's actually side effects that are still being worked through, and how might we do that? And I understand what you're saying is, maybe drawing on some of these tools, but that's with the folks you are working with, and you have developed a lot of those tools. How about the clinicians that people are going to see and they're saying, I'm kind of struggling with the dose I'm on right now. What should I do at this point? So what's the recommendation? And my other question is, what about the whole cognitive behavioral therapy too? I think that that's such an important part and has been shown in many studies to be beneficial in addition to medicines if necessary. So what about those two areas, and how do we maybe help patients and also the clinicians out there to not just be like, oh, then you must need this?
It's a good question, Donna. So one of the tools that is used in deprescribing, specifically with SSRIs, is called the Discontinuation Emergent Signs and Symptoms Scale, DESS. So that's one of the scales that we use to sort of score withdrawal and discontinuation syndrome for patients. And that's from a clinician perspective. And I utilize that tool as well. It's basically I think it's like a 43-point questionnaire. And every time I have a follow-up with a patient, I kind of review that to see if there's any new symptoms that emerge, or sort of if there's any symptoms that are progressing and worsening. And that's kind of how we can pinpoint in terms of where the patient is at. Are they experiencing withdrawal symptoms? And then other things you have to consider are things like, for example, past history. How was the patient sort of prescribed and sort of diagnosed with their condition? What kind of scales and sort of rating scores were they using, whether it's for depression with the HAM-D or PHQ-9 or with anxiety? That's not my area of expertise. Obviously, I'm not a physician, so I don't diagnose. But from a clinician perspective, with the physicians, when they're following up with these patients, kind of going back in their notes and saying, okay, what did the patient initially present with? What were their symptoms of anxiety? What were their symptoms of depression? And then when they're on that journey of deprescribing and tapering off their medication, if they notice that some of these symptoms are coming back, in addition, you may have physical symptoms or other symptoms that sort of distinguish the withdrawal, like the electric zaps, for example. That's how they can say, okay, you know what, maybe we need to pump the brakes a little bit and slow down our process of tapering. And I always kind of counsel and coach my patients in that regard as well. In the journey of deprescribing, I like to call them phases of the phases of the taper as you're going down from dose to dose. There's no harm and there's no sort of feeling of guilt of going back up if you have to as well, because it is a process at the end of the day. And sometimes, depending on how the patient is presenting, external factors in their life as well, like you had mentioned, Donna, if they're not getting cognitive behavioral therapy, or if they're not sort of pursuing these other modalities and not beefing up their sort of mental health toolkit, then they may be more sensitive and sort of more trepidatious in progressing in that taper. So there's no harm in halting the progress. I have a few patients where that's been the case, where we're progressing, they've significantly cut back on their dose. It's getting lower and lower, but then they reach a point where they just feel like symptoms are coming back, rumination or anxiety or whatever have you. And having that conversation with their primary care physician, we understand, okay, you know, for this particular patient, yes, these were the symptoms that she was really struggling with. That's why it was the initial reason why we had diagnosed her with XYZ, and that's why we prescribed XYZ. So then having that sort of open communication with the physician and the patient and part of the circle of care, and saying from now on, maybe we can stop this progress and sort of deprescribing and say we can come back to it later. So really it's all about kind of being patient, being sort of upfront, making sure everyone's on the same page. And that's something I think is very important with patients as well, as making sure you have a trusted pharmacist or a trusted physician where you're having open lines of communication, because at the end of the day, making sure everyone is on the same page is very important in this process.
For sure.
Wow. Yeah, I think when you mentioned the process and you started off the show and talked about, you know, the typical taper of just saying we're reducing the dose one step at a time and gradually going down to zero, right? And the gradual is you usually take a percentage, so 20% reduction, 10% reduction, whatever it might be over X period of time. So X number of weeks. Very common to do. Sometimes for the audience out there, you will see some tapers leverage another therapeutic agent. So what ends up happening is you start on this drug and then you transfer to another drug, oftentimes because that drug, what we call half-life, how long it lasts in the body, can be longer and therefore a little bit more well tolerated. But there's some interesting pieces, I guess, in there that I wanted you to kind of explore in this Horowitz paper with us. We knew that medications like benzodiazepines, diazepam, for example, lorazepam, et cetera, coming off of benzodiazepines can be a very difficult thing. Coming off of opiates can be a very difficult thing. And here's my analogy. I promise to be able to plug in there, Shawn. You can tell me if it's good or not. It's end season, so this is what I'm going to use. So the one thing that we often look at is, let's say that we have everybody's practicing on a court and there are 2 baskets, but there are 4 kids that are shooting at that basket, right? If you want the basket to have a maximum number of balls going through it at all times, always having a basket and bucket rotation, you can get rid of 1 kid and you're still going to have that maximum flow of basket and bucket going through. You can get rid of a 2nd kid and now you can see that you still have that maximum, but you get rid of that 3rd kid and you've just reduced it by half. And so interestingly, when it comes to like our receptors in our bodies, that's what we're targeting with drugs, right? So we're trying to find a way for our drugs to be able to contact receptors. And what we'll notice sometimes is tapering. The initial taper is just fine because we have plenty of drug and a limited number of receptors. But as we go further and further down that tapering range, now we start to see there's a massive shift in the number of receptors that are being contacted, number of baskets that are having balls put in them. There you go. There's my March Madness.
Well done. Well done.
I appreciate the effort. It's kind of a stretch, but I was following along. I'm a big basketball fan, so I did enjoy that, but a bit of a stretch, Kevin.
It's March Madness.
Because of the stretch there, Shawn, I think the one thing I'd rather you do is bring us back into the context of what the Horowitz paper is really looking at and why it should matter so much to individuals that tapering doesn't happen for them on such a sequential basis, but oftentimes more on an exponential basis.
Yeah, so the paper you're referring to is just sort of a review on the hyperbolic nature of these drugs, basically. So it's a great analogy, Kevin. The analogy I like to use is when you look at the curve in terms of the concentration of the medication or the dose and what's happening at the receptor, most of the activity is actually occurring below therapeutic doses. So, for example, in the slide that you have there with citalopram, I believe it is, and you have the dose on the x-axis, and on the y-axis you have the receptor occupancy. You can see that these medications are usually available, and I think for citalopram, 10 milligram, 20 milligram, it comes in standard tablets. But you can see based on that graph there that at the 10 milligram mark, most of the receptors are already occupied, which is why when patients start these medications, for example, we don't really see this in medicine in general, but doubling the dose from a 10 to 20 milligram doesn't necessarily produce a 2x in effect. And on the contrary, when you're coming off these medications, you can see based on the curve there as well that below therapeutic doses, so if you have a 10 milligram tablet, you can maybe half that or quarter that to 5 and 2.5 milligram respectively, you're still occupying a lot of the receptors. So the analogy I like to use is that with the linear taper, so in this case, if you had a physician and a patient on citalopram 20 milligram, they'd say go to 10 for maybe 2 weeks, go to 5 for 2 weeks, and maybe 2.5 for 2 weeks, and off you go. It's almost like the analogy I like to use is imagine you're on the 10th story of a skyscraper and you're walking down the flight of stairs, and no problem. You go down one flight, then the second flight, and the third flight, and you're on the 7th floor. And imagine now you have to jump to the bottom. That's kind of what we're asking our patients to do in these sort of situations, which is why Mark Horowitz and David Taylor, they sort of advocate for a hyperbolic approach, which is the approach that I utilize as well in my practice. And it's a much slower process. And in terms of when we're looking at what's happening, because it follows that hyperbolic curve, the lower the dose, you're still getting a lot of receptor occupancy, which is why patients oftentimes, in my experience as well, they really struggle at the end because they see that the dose is going very low. For example, back to citalopram. I've never done a citalopram. I've done escitalopram though before, so they're very similar. But I have patients on 1.4 milligram, 1.1 milligram. And the mentality is, I'm so close to zero. I can just jump off. I can go cold turkey. I can do it. But then they realize that you're still occupying a lot of receptors. So when you understand the pharmacology and actually what's happening in the body, and I always kind of counsel and educate my patients in this regard, and I show them the paper and I show them what's happening, because they then see, they visualize it, they understand what's happening. They can then make sense of why they're experiencing withdrawal, why they're experiencing these symptoms. So it does empower them, and at least it provides them a little bit of source of relief, because patients that don't have this sort of information, they go from a 5 milligram to zero. All of a sudden, they get that flood of anxiety comes back, and it's almost like they're getting sort of a confirmation bias and saying, oh, maybe I just have anxiety. Maybe I have a chemical imbalance. And that's one of the issues sort of with this model. And sort of, it's really a disservice to our patients, because we don't feel like the fact that we're following these guidelines, which are outdated, and we're putting patients in these situations. It's almost like we're just kind of putting them on a treadmill and sort of putting them on this sort of path to being on medications for the rest of their life, when that's not the case. And that doesn't have to be the case.
So Shawn, you, I believe, work in a compounding pharmacy and have the ability to compound and be more creative, if you will, with doses like you're talking about, where we certainly couldn't be cutting up a tablet to those doses. I'm also curious, in Canada, in your practice, are you able to reduce the doses yourself as you're working with the patients, or is it still prescriber driven that you have to always get the okay? Or how is that collaborative practice maybe done in Canada?
It's a good question, Donna. So yeah, I do work in a compounding pharmacy, and compounding is highly regulated in the province of Ontario. And it's really beneficial for the patients in the context of deprescribing because we can actually customize their preparations and make oral solutions. There are a lot of resources online. There's a lot of Facebook groups and sort of social media groups out there, and it's great for support and collaboration. But you'll have people kind of make their own kind of homemade recipes of crushing tablets and adding them to water and etc. and whatnot. But I advocate for kind of a compounding approach because that way it kind of takes unnecessary risk out of the patient's hands, puts it into the hands of professionals with pharmacists, and we can compound these medications, assure some stability in the process as well. And then in regards to the physician, absolutely, I advocate for having the physician on board and actually prescribing and being sort of in line with the plan. So what I'll do is part of my sort of services is I coordinate the care between the patient and the physician and the pharmacy. So working in a compound pharmacy, it's very easy for me to reach out to the patient's physician and say, hey, I'm Dr. Shawn Gill. This is the sort of plan that we're working with your patient to help facilitate deprescribing and get them safely off the medication. And the doctors love it. They're usually on board. I connect with them as well and say, we're utilizing a hyperbolic approach. Sometimes they push back and say, maybe the patient might be beneficial to consider just straight using a linear taper, because there are some success stories with linear tapers, and depending on the patient characteristics, they might still be able to go through that process. So it's really a balancing act in that regard, but having the physician on board is imperative. But then what you'll see also when I come across patients, they kind of reach out to me, they're on this journey on their own. And sometimes they feel like this is, again, from patients coming from them, that sometimes the physicians aren't on board. So they kind of take matters into their own hand, where they're crushing tablets in their kitchen sink and adding it to, water and maple syrup and all these different sort of concoctions. So there is risk involved with that. So that's why I always advocate for compounding, because it's accessible. I work in a compounding pharmacy, and it just makes it more sort of less error prone and less sort of risk for the patient as well involved.
Sure.
Wow. So here's personal story time, Donna. I don't think you and I have even talked about this. So when it comes to prescribing antidepressants in general and dispensing antidepressants, so there's one moment that sticks in my career. There was a young gentleman. His mom came to my pharmacy and picked up an antidepressant. I should make sure that I give this caveat. In no means, as it says on all of the MedList podcast areas, are we giving out any medical advice. Always consult your physician and your entire healthcare team before making any decisions. But continuing with the story, this young man ended up committing suicide later on. And so it's always weighed on me, Shawn and Donna, like that element. People might think, well, depression and then committing suicide, they seem to be a logical fit. But having the knowledge and background that we do, it becomes a very difficult thing, Shawn, that I'd love for you to talk a little bit more about that pre-prescribing and some of the risks of starting an antidepressant, because you mentioned, making sure the doctor was on board. One thing that I have changed my practice in general when it comes to antidepressants in particular, I usually want the entire family and their support system to be on board early, right, in the process, so that they have people around them that love them and care about them, that can watch over them during that time when there is a substance being introduced that can cause some very significant issues to happen. So sorry to add a little bit of heaviness here, but I think it's important for us to look at the gravity, right, of what we're actually dealing with. And Shawn, I'd love your perspective on that piece of prescribing or pre-prescribing.
Yeah, absolutely, Kevin. Well, first off, just condolences to that family. It's a tragedy. It's unfortunately becoming very common in our society. So that's one of the reasons why I started this whole initiative with deprescribing and trying to reverse this sort of rising tide of mental health. Back to your question, Kevin, so that's one of the things I try and implement in my sort of practice as a pharmacist, is when I have patients come to me, and like I said, I kind of serve all ages, teenagers, individuals, millennials my age, 20s, 30s, 40s, even older patients as well. Try and have candid conversations with them about sort of the risks of these antidepressants, especially in the youth, because when we look at sort of the trial data as well, we know that risk of suicide can potentially go up in patients under the age of 18. And I know in the sort of the world of psychiatry, there's almost kind of like a civil war brewing in terms of, prescribing these medications and looking at the data and looking at the safety evidence and whatnot. And even recently, the FDA approved SSRIs in patients 7 years old and up to patients that young. So it kind of, paints a a bleak picture of where we're kind of headed. And combating that, I think, is sort of a mission that I'm on, in terms of, it's one of the works I do with my blog, for example, where I try and, write from the perspective of a pharmacist who works in family medicine and pediatrics, but also I'm a father of 2 young boys as well. So trying to kind of bring more awareness and bring more conversation and have discussions about things like mindfulness and meditation and stress and how to deal with it in the context of sort of economic terms and where we're at as a kind of a society in general. So opening up those dialogues with patients when they're getting their medications is important, because, at the end of the day, like I said, with primary care, especially in accessibility, it's almost like, patients are kind of funneling through this sort of system where they don't have much time with, physicians, and there's not much guidance, there's not much education, and it's easy to kind of, be very transactional, where they go in, they see a physician, they put their trust in their health and sort of, these physicians, these amazing physicians' hands. And at the end of the day, I do respect them to the utmost degree, because they're essential and they're integral to our medical system, of course. But at the same time, it's understanding their perspective. They're over leveraged, they're overburdened, they have lineups out the door, they don't have much time with patients. So patients often kind of go away and they feel like they're almost on their own in that regard, and they turn to things like, social media, and they search for information out there. So what I try and do is distill some of the information out there already. Like, I'm heavily invested in this sort of field because, one, I've dealt with my own mental health issues, but at the same time, now that I have young children, I'm invested in their future as well. So that's why I'm on this kind of mission to sort of reverse this trend of rising mental health. And whether it's through blogging, whether it's through podcasting, just having conversations with patients and saying there's alternatives. And the good thing is that I feel like, in certain circles on social media and sort of online, pockets of, these type of groups are rising up and saying, what, we saying no to medication, and instead focusing on things like mindful-based stress reduction, focusing on the benefits of exercise, of community building. All these things are very important, and we have to go back to in regards to sort of, improving our collective mental health and physical health.
Yeah.
Amen.
So, Shawn, I know for the years I've dispensed that so many times, you're giving out that pamphlet, if you will, with the medication, and it gives a lot of this information and increased risk of suicide, et cetera, like we're talking about. And not that I'm saying we're careless about it, but it's almost like the alert fatigue that we get involved in. And, you're just giving out all these pamphlets for all of these meds. And, some are heavier than others, if you will. And maybe we're not as good at, directing folks, saying, you really need to read this too. This is really important. So I love this idea of just that, hey, let's remember to do this. Let's remember not just to put it in the bag with all the other pamphlets. Let's make certain that we are actually sharing the information that's so important for families. So another question I have is in regards, we never see anyone on just one med, it seems, either with mental health issues and even diabetes and even high blood pressure. We know that these types of health issues are typically multi of agents that are being used to treat them. So, with that said, how are we, or how do you choose, or what do you think is the best way to maybe go off of multiple meds? Is it one at a time? Is it many at a time? Is it, if you're going through this process, are you trying to reduce multiple meds slowly? Or how do we look at these things? And do you have any, like, quote unquote tricks of the trade, or how you might approach multiple meds for mental health?
That's a great question, Donna, and it's very difficult, to be honest. In my practice, it's usually like monotherapy, SSRIs, but I have had some cases of patients being on multiple medications, and it gets very tricky in terms of what to deprescribe first, especially in the context of mental health.
Yeah.
Mental health, especially, for example, like anxiety or depression, where you have a patient maybe on an SSRI, like sertraline, for example, but then they're also prescribed an additional agent, like whether it's quetiapine or bupropion, for example. It gets very tricky and very messy in the waters. But my approach, I've had one patient where I've helped them on their process. They're no longer a patient of mine, but they were on an SSRI and bupropion But the bupropion was kind of added almost as a prescribing cascade where they had some side effects potentially, and the doctor suggested, let's try this, let's add this as kind of augmentation therapy, just to boost the effect of the SSRI. And my suggestion was, let's try and take you off the SSRI first, and then we can deal with the bupropion. But then, like I said, this is such a field in its infancy in terms of deprescribing, especially in the context of mental health. We don't really have much guidance, and we're kind of going based on case reports and kind of anecdotal evidence and sort of our own clinical practices. But that's not really an area of my practice that I focus on. I try and target monotherapy patients. And on the context of like a cardiovascular disease or type 2 diabetes, it's much more, there's much more evidence in terms of looking at the most beneficial agents for an individual with type 2 diabetes. Say they're on, for example, like metformin and Jardiance and sitagliptin, for example. Like once the A1C begins to improve and you're starting hitting those outcomes, then you can, it's easier to take off other medications one at a time. And keeping on the medications that have sort of the best benefit in terms of their evidence for supporting sort of clinical outcomes, metformin probably being the best one. And in my context of helping patients with type 2 diabetes, like I have a couple of clinical cases where patients, they're on metformin, they're on another agent, their A1C is improving, and we take them off the other agent, we maintain metformin, and as their A1C continues to improve, gets below 6.5, almost to 6%, we can consider deprescribing off metformin. But then it's a conversation to have with the physician as well, and understanding, depends on the patient, where the patient is in terms of their context, their family history, where they're on in their stage of life as well. Like one of my patients, she's in her 60s and she's doing really well. Her markers are great. Fasting blood glucose averages in her mid 5s. A1C is coming up soon and anticipating under 6%, and she's on metformin 500 once daily. She's living an incredibly healthy lifestyle, eating the right foods. She's very energetic, going on walks every single day, exercising, weightlifting. It's an amazing case, and it's an amazing success story. And I've had that conversation and saying, hey, you know what? You don't have any family history of cardiovascular disease. You don't have any family history of diabetes as well. You basically reversed it on your own. So congratulations to you. And so that conversation next that we can have with the doctor is saying, hey, A1C is perfect. Fasting blood glucose average is great. Maybe let's consider getting off metformin.
Yeah, for sure.
But from a longevity perspective as well, I do follow some of the research and the evidence in that field as well. So there might be some really good benefits of being on metformin long term. So it's always kind of it's clinical context at the end of the day, and sort of what we're kind of what options we're weighing here as well. So I am a fan of metformin, but it depends, right? It depends on clinical sort of case and context.
I'm on the fan of reversing type 2 diabetes. So
absolutely.
Awesome.
We can all agree on that one for sure. I just had two, Donna, that I wanted to make sure I got to Shawn, but I know we're running up on time here. So I'll make one of them a shortened version, Shawn. So the two are really this. One was you've mentioned several times, which I love, your mental health toolkit, which I think is a beautiful way of laying that out. Like, what do you have available to you when things start getting difficult, right? So I'll shorten that question by asking you this. Good resources for our listeners and folks out there that have for their patients to go and look at, to be able to build that toolkit either independently or through additional help.
Oh, absolutely. So I always recommend kind of a few sort of my go-tos for building that toolkit. So the first one is a good meditation app that I recommend. I'm not sponsored by them, but I advocate for Waking Up by Sam Harris. It's an amazing app. I actually started using that app when it was in its beta testing for stages. So back when there was like nothing on there, just like 10 meditations, but it's grown into a wonderful resource for me and for my patients. They have courses on cognitive behavioral therapy. They have philosophy on there. They have guided meditations, adults and children. And the best thing about that app is that it is subscription based, but they have scholarship programs as well. So they do offer it for free. So that's one of my go-to apps for meditation. There's a lot of amazing clinicians in the space of mindfulness-based stress reduction. Dr. Judd Brewer, he's got a great collection of books on the field of meditation and mindfulness. And then I always kind of coach my patients on little things that they can begin sort of implementing into their life. For example, little things like little challenges. One of my favorite authors is Michael Easter. He's got a great book called The Comfort Crisis, how a lot of our mental health issues are stooped in the fact that our society has become too comfortable. So I kind of challenge my patients to consider things like cold exposure. I've been doing cold showers now for about 5 years, so I was kind of ahead of the trend. But I think it's a great way to just kind of test your limits and build sort of mental resilience. Of course, physical exercise is an essential component and staple of, I believe that if you're sort of working on your body naturally, the mind follows movement. So it's a great way to kind of reduce stress. And then I advocate for breath work as well. Wim Hof method, box breathing, 4-7-8, whatever kind of is your process. I think breath work is an essential kind of component of helping us kind of get back into that rest and digest, vagus nerve stimulation and whatnot. So I'm a big advocate for sort of breathing techniques as well. And these are things I kind of coach and counsel my patients on as well in their journey, and just kind of share a lot of resources and education in that front.
No, that's super helpful. And so anybody, please re-listen to some of the things that were just mentioned there, because I feel like that mental health toolbox is not advocated for often enough, and that we have those additional abilities for our patients to be able to gain a greater hold on their own mental health. Personal relationship with their mental health is so important. So speaking of that, the other piece of a personal relationship with your mental health is monitoring, Shawn. And so I was hoping you could give us a little bit of information when it comes to how should a patient, if they are going on to an SRI or other treatment for mental health, how should they monitor themselves, and what things should they be looking out for when they're starting a therapy or coming off?
Oh, that's a great question. So I have a template that I give my patients. It's a goals of therapy template, basically, where it's just a table. I outline basically a lot of parameters that we usually measure in regards to whether their condition is anxiety or depression, just kind of outlining the symptom that they're trying to focus on. Everyone has different manifestations for depression or anxiety or mental health, right? Some people, when they're anxious, they can't focus at work, they can't get tasks done. Some people, they get sweating, or the symptoms are kind of unlimited, right? So it's identifying specifically what you're aiming to reduce, outlining kind of the goal of that to reduce that symptom, and putting in a time frame and actually measuring it, because so much of mental health, a lot of it unfortunately is subjective in nature. It's like asking someone how they were doing 3 months ago. It can be, it's not like as objective as something like, for example, blood pressure or diabetes, where we can physically monitor. And of course, like I said, I'm not a physician. That's not my job. My job isn't to kind of monitor patients from that perspective, but I try and coach my patients and say, let's actually establish what your goals of therapy are, so that you have something you can go back to and say, 3 months ago, I was in this kind of state. This is what I was feeling, and how am I feeling now? And one of the things I help my patients advocate, or I help my patients sort of implement that, is through journaling techniques as well. Keeping a daily journal, sort of some prompts that you can use to kind of sort of at least go back in time and say, okay, on this date, this is how I was feeling. This is what was kind of going through my life right now. And that's an objective way we can go back as well and look at and see if we're changing sort of mentally as well in that regard.
That's awesome. Fabulous. Thank you so much, Shawn. Really appreciate your time and great tools and thinking forward and just being proactive from the first prescription or pre-prescription right on through deprescribing. So thank you so much for your time with us, and just a wealth of information for all of our audiences.
Oh, it's been a pleasure, Don. I really appreciate you and Kevin taking the time to chat with me.
Yeah, wonderful job, Shawn. Really thankful for your time and your insights on everything there, and kind of your holistic approach. I hope that those listeners that are on board, if you took anything away, the way that Shawn approaches medicine, of looking at it prior to starting a therapy all the way through and having an end plan, is something that I think from a societal standpoint, from a healthcare system standpoint, we have to start adopting in general and start including some of those steps into the way we're practicing. Today, we're not there yet. And so there does take a level of onus on patient shoulders in order to feel emboldened, feel empowered to take advantage of, you have the authority over your own healthcare, over your own mental health. And so I really appreciate that, Shawn. Any parting words, Shawn, for the audience? I wanted to give you one last chance to plug anything in.
Oh, no, just if you're interested in following my work, you can check out my website, drshawngill.com, or you can follow me on Substack. Again, my Substack is called BUDS. It stands for Building a Community, Understanding the World Through Compassion and Curiosity, Discipline and Physical and Mental Training, and Stillness and Presence. And just things that I've learned in my journey as, a father and a pharmacist, and trying to make the world a better place. And one of my favorite sayings is from Confucius, to move a mountain, you have to start with moving small stones. And that's kind of my mission, and that's what I'm trying to do.
Awesome.
Thankful for you moving those small stones, buddy, and hope we can help you along the way. Thanks so much, everybody. We did add new episodes on Spotify and Apple Podcasts. We uploaded 4 new ones, and so you guys can check those out. This one with Shawn will be available here very soon. Thankful for everybody who is subscribing, and until then, Take care and have a wonderful rest of the day.